Alright, so this is our scrubs video for the gluteal region and the posterior thigh. My name is Ryan Dickerson. I'm a Brady student, class 2025, and let's go ahead and get into it. So before we get started, the mission statement for Scrubs. Scrubs is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody. And members of Scrubs, we participate in a variety of subcommittees to gather these resources for students by students. We offer a unique perspective because we are students and we've gone through these courses ourselves. So we hope to give you that unique perspective. If this is something that you are interested in joining, we always are welcoming new members, and we hope that this leaves an everlasting mark on Brody. So, as with all of our resources, a brief disclaimer, these resources are made by students and not by faculty. As such, there is the possibility for errors. We do our best to minimize these, but it is possible as students that we do make errors due to our lack of overall understanding as we're going through this material. If there is ever a contradiction in the coursework and the material presented in your course, as well as curriculum changing over time, please go by your course documents. Additionally, this is a supplemental resource. It is not your primary resource. That should be your Brody faculty. So with that, let's go ahead and get into the material. So let's start with some bony landmarks. This is a quick review of the pelvis, but there are bony landmarks that you are going to need to know in order to understand the origins and insertions of the gluteal muscles, as well as their action on the hip joint, as well as the knee. So start anteriorly, we have our big bones. Let's just start with sacrum, ilium. Up here we have the pubis, and then down here we have the ischium. Now, what I want to point out here is that there is the sacroiliac joint posteriorly, and then anteriorly we have the anterior superior iliac spine and the anterior inferior iliac spine. These are, again, insertions and origins for different muscles that we've already seen in the anterior compartment of the leg, or of the thigh. Now, one that we're going to want to notice here is the ischial spine, which is located posteriorly. We can see that on either side, ischial spine here, and then the ischial tuberosity. These are going to become important landmarks for this particular video. I additionally want to point out that just like you had an anterior superior iliac spine, you have a posterior superior iliac spine, and just below that, the posterior inferior iliac spine. Now, do remember that when we talk about the pelvis, there are ligaments that join from the ischial spine to the sacrum, sacrospinous ligament, and then we have a ligament that goes from the sacrum to the ischial tuberosity, sacrospinous ligament, and then tuberous ligament. Now again, these are going to be important landmarks when we're talking about the sciatic foramen. We have a greater sciatic foramen up here, and then down here we'll have the lesser sciatic foramen. And these are going to be important when we're talking about structures running in and out of the sciatic foramen. So before we get to that, we are going to do a review of the different foramen and the structures running out. Let's go ahead and review a little bit of the femur anatomy. So when we're talking about the femur, again, this is an anterior view and a posterior view. There are a couple of important structures you need to know. We're mostly going to be focused on the posterior view for this video, but let's go over the anterior view just while we're here. Again, on the anterior view between the greater trochanter and lesser trochanter, there is a intertrochanteric line. The line is on the anterior aspect of the femur. The posterior aspect has an intertrochanteric crest. I remember this, the difference between crest and line being anterior for the line, posterior for the crest, is crest, like crack, starts with a C, and so that should be in the posterior aspect. Now, on the posterior aspect of the femur, the way that we identify posterior versus anterior, if you get this in lab, is that there is a very clear linea aspera. You're going to see that this is both the origin and insertion of multiple muscles for the thigh and the leg. I want to point out, you have a gluteal tuberosity. Gluteal tuberosity is on the posterior aspect of the femur, just beneath the intertrochanteric crest. So gluteal tuberosity here. And then on the medial aspect, kind of posteriorly, we have the pectineal line. And this is the insertion of our pectineus muscle, which we reviewed in a previous video. And lastly, the adductor tubercle. Again, medial aspect of the femur, located a little bit posteriorly, but most of this on the medial aspect. And right here above the medial epicondyle, that is the adductor tubercle, and that is the insertion of our adductor magnus muscle. All right, now let's go through a quick review of the structures that come in and out of the greater and lesser sciatic foramen. So I really enjoy this this photo because I think it does a great job of giving you an overview of the structures that you need to know. But with the greater and lesser sciatic foramen. Again, the greater sciatic foramen here, make sure you know the borders. That was covered in a previous video, so I won't do that now. But the big thing that comes out of the greater sciatic foramen that is going to delineate structures coming above and below is this piriformis muscle. This is going to be an important landmark because what you'll see in lab is that we're going to talk about some nerves and some vessels today. And you can identify in lab the nerve versus the vessel based on if it runs above the piriformis muscle or below the piriformis muscle. All are running through the greater sciatic foramen, but it can tell you, help you identify the structures if it's above or below the piriformis muscle. So it's a really important landmark to know for lab. So let's start talking about the structures that run above the piriformis muscle. Here, you're going to get structures coming out of the greater sciatic foramen above the piriformis muscle. This is your superior gluteal artery and superior gluteal nerve. And that makes sense. It's above the piriformis muscle, so it's superior. Coming through the greater sciatic foramen. Coming below the greater sciatic foramen, in the greater sciatic foramen below the piriformis muscle is everything else. So you're going to have your inferior gluteal artery, inferior gluteal nerve. Okay, you're also going to have your sciatic nerve, which if you remember is made up of two other nerves, the tibial nerve and the common fibular nerve. And then you're going to get your posterior femoral cutaneous nerve, which is doing the skin on the posterior thigh and a little bit of the buttocks region. Now here, what I want to point out is you have your pudendal nerve. The pudendal nerve is going to come out of the greater sciatic foramen below the piriformis muscle, but then it's actually going to wrap around your sacrospinous ligament. So it comes out, wraps around the sacrospinous ligament, and then dives in to your lesser sciatic foramen. So the pudendal nerve, very important to know this, and the internal pudendal artery and vein are going to come around, wrap over top of the sacrospinous ligament, and go into the lesser sciatic foramen. They're going to run into your perineum. All this was covered in more detail in a previous video. Now, the only structure that you need to know that comes out of the lesser sciatic foramen, important here, we're talking about coming out, not going in, is going to be the tendon of the obturator internus muscle. Now, the tendon of the obturator internus muscle is going to be a super important landmark when we're talking about identifying muscles in the gluteal region. So when you're looking in this posterior aspect in the lab, the big things that you want to look for landmarks is going to be your piriformis muscle coming across. That's going to help you identify neurovascular structures. And then you're going to want to look for your tendon of the obturator internus muscle, which will be coming through the lesser sciatic foramen and inserting onto the greater trochanter, and that's going to help you identify some other muscles that we're going to talk about in just a moment. Before we talk about the deep muscles of the gluteal region, let's start a little bit superficially and then we'll work our way deep. So the first muscle that I want to talk about is one we're all familiar with, the gluteus maximus muscle. So here's your gluteus maximus muscle here. And the important parts that you need to know is origin, insertions, innervation, and action. These are the four main components for any muscle that we're going to talk about for the remainder of this video. So for the gluteus maximus muscle, it's going to originate from the iliac crest, part of the sacrum, and then also your sacrotuberous ligament, which remember is going from the sacrum to your ischial tuberosity. So it's going to be in this region here. And then it's going to insert onto the gluteal tuberosity. Remember we saw that on the posterior aspect of the femur, just below the intertrochanteric crest. So that is your gluteal tuberosity. Now the nerve that innervates this muscle, somewhat infuriating to me, is the inferior gluteal nerve. You would really think gluteus maximus is the biggest muscle back here in the posterior aspect of the your pelvis, so you would really want this to be superior gluteal, but just remember, gluteus maximus, inferior gluteal nerve, and the inferior gluteal nerve spinal segments are L5 through S2. I highly recommend making sure that you know your lumbosacral plexus prior to watching this video. The lumbosacral plexus is a phenomenal way to go through the different structures and musculature and innervation all in one quick drawing to really help you aid in your studies. Now, going to the action, this muscle is important to note because it is an extensor of the thigh. So it brings the thigh backwards, so kind of taking your heel and putting it behind you, lateral rotation, and it is the only adductor of these superficial muscles that we're going to talk about. So adduction. So when I think about the gluteus maximus muscle and its function, I think about standing on one leg and then taking my other leg, and I'm going to bring it behind me and across my body. And that is going to give you the rough action of the gluteus maximus muscle. Now, the gluteus medius, minimus, and tensor fasciae latae are all nice because they have very similar actions, and they're all innervated by the same nerve. So, all these muscles are innervated by the superior gluteal nerve, L4 through S1. let's go through and identify these one by one. So the first one we're going to say right here is the gluteus medius muscle. So you notice this is underneath the gluteus maximus. So when you're in lab, you're going to have to reflect the gluteus maximus to see the gluteus medius. And then the gluteus minimus is actually underneath the gluteus medius muscle, just not shown in this image. It would originate right in this region, and it would come down and insert onto the same location. So just two separate muscles, one's superficial, one's deep. So medius is more superficial to minimus. Now, the origin for the gluteus medius is the ilium, the fascia of the gluteus maximus, so kind of in this region. And you can see that here. And then it is going to insert into the greater trochanter, as all of these muscles will. And again, its function is to abduct and medially rotate the thigh. And so when you're thinking about this function, if you've ever done the fire hydrant exercise in the gym, where you are on floors and then you bring your leg up to the side at a 90-degree angle, that is going to be the rough action of your gluteus medius muscle, along with the minimus. Has the same functions, roughly same origin and insertion. It's just going to be a little bit deeper to the gluteus medius, and again, same action and innervation. The tensor fascia lata of the thigh is going to be the most lateral muscle back here in the gluteal region. It is a superficial muscle, and it is arising from the iliac crest up in here, and the anterior aspect is the anterior superior iliac spine. So remember, we have a couple muscles now that are coming from the anterior superior iliac spine. So this is one of those. The insertion of this muscle is your IT tract that comes down the lateral aspect of your leg. So iliotibial tract coming down here, and that it's once again innervated by the superior gluteal nerve, L4 through S1. It is going to aid in the same actions as your glute med and glute min, abduction and medial rotation, although this has an additional function of flexion because it does cross anteriorly over the top of the hip joint. So no flexion is special for the tensor fascia lata of the thigh. And then the glute maximus is really the special muscle in this superficial gluteal region, as it is innervated by a different nerve, the inferior gluteal nerve, which has spinal segments L5 through S2, and is the only one that is going to aid in adduction of the thigh. Now, as we continue and to look at the deeper structures of the gluteal region, this is where it comes in really important. Do you remember your greater sciatic foramen, lesser sciatic foramen, and the structures that are going through both of those? What I look for here is we're going to start with the sciatic foramens. Up here is the greater sciatic foramen. I see that sacrospinous ligament right here. That marks the inferior border of your greater sciatic foramen. And then right here is your lesser sciatic foramen, circled right there. So what I want to point out is that there are two major muscles that are coming out of each one of these foramen that are great landmarks, because muscles, as you've noticed at this point, are very large and easy to identify. So the first one coming out of the greater sciatic foramen is this piriformis muscle. And again, we mentioned that the piriformis muscle is going to be an important landmark because you're going to have neurovascular bundles coming out superiorly and neurovascular bundles coming out inferiorly. If you recall, what is the neurovascular bundle that comes out superiorly? That is your superior gluteal artery and nerve innervating your glute min, glute med, and your tensor fascia lata of the thigh, which will be located over here laterally. So that makes sense. They're all located in the same region. So superior gluteal nerve and artery, again, remember the spinal segments for that. You're going to have L4 through S1. Okay, going back to the muscles, the piriformis muscle. So piriformis muscle located here. It is originating from the anterior surface of the sacral vertebrae, so back in the pelvis, so anteriorly to this the sacrum. It is coming through the greater sciatic foramen and inserting onto the greater trochanter. You're starting to notice that there are a lot of muscles inserting onto the greater trochanter. The innervation, amazing, nerve to the piriformis. Innervated by the nerve that has the same name. Great. Now I need to remember the spinal segments S1 through S2. This is off the posterior division of the sacral plexus. And this action, lateral rotation of the thigh. You're going to see all of these muscles that we're talking about here are going to have lateral rotation of the thigh as their primary action. Next, we have our superior gemellus. Now, before I go to the superior gemellus, just some identification things. Piriformis coming down, and then we look through the lesser sciatic foramen. There's this muscle that comes across. This is the obturator internus, and usually in lab we're going to see this as a tendon as it comes through. I use this tendon a ton for identification. One, it tells me that the lesser sciatic foramen is here, but also you notice it's splitting two muscles. There's a muscle directly above and a muscle directly below. The muscle directly above is going to be your superior gemellus muscle. The muscle below is your inferior gemellus. So if you can identify your obturator internus, you know the muscle directly above and below to help aid in identification. So let's talk about the superior gemellus. It's originating from the ischial spine. And we can see that. There goes the ischial spine there, and there goes its origin. So it's originating from the ischial spine, and it's inserting into the greater trochanter. This muscle is going to be innervated by the nerve to the superior gemellus and obturator internus. Well, what do you know? They're side by side, so it makes sense that the nerve that innervates these, or the nerve innervates both of these muscles if it's running in between. So if you see a nerve going directly into the superior gemellus, you're going to say, hey, that's the nerve to superior gemellus and obturator internus. That's going to be L5 through S2. And once again, action is lateral rotation of the thigh. Next, I have the obturator internus. And again, look at this. Passes through the inferior sciatic foramen. That is super important because it's identification. It is going to arise from the ilium. So that is up in the anterior aspect. And then it is going to pass through the lesser sciatic foramen, come in lateral to the greater trochanter for lateral rotation of the thigh. And we already talked about the nerve that innervates this. It's the nerve to superior gemellus and obturator internus, L5 through S2. Next, we come down to our inferior gemellus. And what do you know? We come down inferiorly. Instead of originating from the ischial spine, it's originating from the ischial tuberosity. So again, inferior on the pelvis. That's why our bony landmarks are so important. So it helps us understand where these muscles are originating and inserting and how that's going to change their location as well as their action. So the ischial tuberosity here, and then inserting into the greater trochanter. This muscle is innervated by a separate nerve. It is the nerve to inferior gemellus and quadratus femoris. You say, well, Ron, I know what this inferior gemellus is now that you showed me, but what's the quadratus femoris? Well, look, directly below the inferior gemellus, you have another muscle, and it's a little bit bigger muscle, and it's shaped kind of like a square. So that's where it gets its name. This is the quadratus femoris muscle. So, great. Just like the superior gemellus and obturator internus, these muscles are side by side, innervated by the same nerve. Well, the next two muscles in this set are also innervated by the same nerve. This is the nerve to the inferior gemellus and quadratus femoris muscle. And both of these muscles are going to aid in lateral rotation of the thigh. Now, I do want to point out spinal segments real quick. You need to remember the superior gemellus and obturator internus. While they are superior in the musculature, their spinal segments are one less than the inferior gemellus and quadratus femoris. So, the nerve to superior gemellus and obturator internus has spinal segments L5 through S2. The nerve to inferior gemellus and quadratus femoris are instead going to have spinal segments L4 through S1. So even though they're located more inferiorly in the anatomical position, the spinal segments associated are going to be reversed in that orientation. Okay, lastly, the quadratus femoris. We identified it here. Quadratus femoris is originating from the ischial tuberosity, just like the inferior gemellus is. So that helps me pair those together as well. Now, instead of inserting into the greater trochanter, it is going to insert into the intratrochanteric crest. And remember that crest is posterior. Again, innervated by the nerve to inferior gemellus and quadratus femoris, and as all these muscles do, aiding in lateral rotation of the thigh. So lateral rotation of the thigh here. All right, and that takes us through the muscles of the gluteal region. Now that we've covered the muscles of the gluteal region, we now need to cover the muscles of the posterior thigh. And I'm going to make this simple. There are very few muscles of the posterior thigh. There's really 3, and then one of those has 2 heads. So 4 muscles total. The innervation is going to be relatively straightforward, and their actions are all very similar. So let's start off going from medial to lateral. So we're looking at the posterior thigh here. So let's start with hamstring muscles. Your hamstring muscles are defined as originating from your ischial tuberosity and coming down across the knee joint. So you only have 3 hamstring muscles. The first one is going to be the semimembranous muscle. And I use the M here for semimembranous to tell me that this is the most medial muscle. So that is going to be identified by number 2 here, the semimembranous muscle. It is coming down, is again originating from ischial tuberosity. So remember, ischial tuberosity helps me identify this is a hamstring muscle. It is going to insert onto the medial surface of the tibia. So we follow it coming down, and it inserts onto the medial surface of the tibia, which is that bone in the leg, and then it is innervated by the tibial nerve. Okay, you're going to see most of these muscles, all your hamstring muscles, are innervated by the tibial nerve. And its action is going to be to extend the thigh and flex the knee. So it extends the thigh because it is posterior, it crosses the hip joint, and it can flex the knee. It is really important that you know the difference between flexion and extension at the knee joint, because it's crossing the knee joint posteriorly. So that's the semimembranous. M for medial. Next, the semitendinous. That is going to be identified by number 1 here. It is directly beside the semimembranous, so both are coming medially, and it's going to cross over to the medial aspect of the tibia, specifically inserting into the pes anserine, which was covered in the flexor compartment video. And again, tibial nerve, because this is a hamstring muscle, tibial nerve originating from the ischial tuberosity. Those are kind of the things that you need to keep in pairing with the hamstring muscles. And again, action, extend the thigh, flex the knee. Same as we saw with the semimembranous. The only important part in identifying these is one is more medial than the other. Next, you have your bicep femoris, and it's important to note here that there is a long head and a short head. These are going to be the long head, look at this, originating from the ischial tuberosity. That is going to tell me it is part of the hamstring muscles, meaning it is going to be innervated by the tibial nerve, right, and originating from the ischial tuberosity. So that is the long head. The short head, however, is going to originate from the femur itself. So here it is in 3b, originates from the femur itself, comes down and joins the common tendon to insert into the head of the fibula. But because it does not originate from the ischial tuberosity, it is not one of the hamstring muscles, it is not innervated by the tibial nerve. It is instead innervated by the common fibular nerve here. Okay, and so that is the short head of the biceps femoris. The overall action of the bicep femoris is going to be to extend the thigh and flex the knee, same as all of these other muscles. Lastly, kind of going back to the muscles of the adductor compartment of the thigh, we do have the vertical fibers of the adductor magnus. Specifically here, these are the vertical fibers. So this is important to note because it does arise from the ischial tuberosity, come down and crosses the knee, so you can consider this part of the hamstring muscles, given that definition. And because it's part of the hamstring muscles, these vertical fibers are going to be innervated by the tibial nerve. It's important to note here, again, that this is specifically talking about the vertical fibers. The horizontal fibers have a different mechanism based on the fiber direction, and those are innervated by the obturator nerve. So the adductor magnus has split innervation. And the action here, extend the thigh, flex the knee, inserting into the adductor tubercle of the femur. Now that we've covered the musculature of the region, I think this makes it a little bit easier to identify the neurovascular bundles if we keep the musculature in mind, because we can use that as landmarks. So we already talked about the piriformis muscle coming through. That's a big landmark to identify coming through the greater sciatic foramen. If we look up here, there goes the piriformis muscle. Fantastic. So piriformis muscle coming directly through the greater sciatic foramen. And we look directly above it. We see a nerve and an artery. Well, what could those be? If it's coming through the greater sciatic foramen, and identified that by looking at the piriformis muscle, coming above the piriformis muscle, supplying the gluteus medius and gluteus minimus, then this tells me that this is the superior gluteal nerve and superior gluteal artery. So superior gluteal nerve, superior gluteal artery coming above the piriformis muscle. Next, I come down here below the piriformis muscle. This is going to be still coming through my greater sciatic foramen, but below the piriformis muscle, and this is going to be where everything else is coming out. So you see this major nerve coming down. Well, this large nerve is going to be my sciatic nerve. You see it running into the posterior aspect of the thigh. So this is the sciatic nerve coming down to supply all the structures in my lower limb. But directly beside it, we have a smaller nerve that is going to be coming off a little bit more superiorly, but going in the same direction. And this nerve is going to be my posterior femoral cutaneous nerve. So go back to the lumbosacral plexus if you need a little bit more review on that. So these two nerves run kind of side by side. One is just a little bit more superficial, going to be supplying the skin, whereas the sciatic nerve is coming down to supply all the structures in the lower limb. And then next we have this nerve coming through that comes out, and look at that, it's wrapping around. And there goes my sacrotuberous ligament. So that marks the inferior border of my lesser sciatic foramen. So if it's coming out the greater sciatic foramen beneath the piriformis muscle, wrapping into the lesser sciatic foramen, then this is going to tell me that this is my pudendal artery, my internal pudendal artery and pudendal nerve bundle. And lastly, we have this nerve coming out below the piriformis muscle, and then it runs up to supply the gluteus maximus and kind of branching out. Well, I know what nerve innervates the gluteus maximus. It's the inferior gluteal nerve, and the artery that runs with it, the inferior gluteal artery. So that's how you identify the neurovascular bundles in the posterior aspect of the gluteal region based off of the musculature that you're seeing associated. And then quick review on the other muscles. Look right here. You have 1, 2, 3 muscles in a bundle. The one that runs right through the middle and splits them is the obturator internus. So there goes the tendon of the obturator internus muscle. The muscle directly above has to be the superior gemellus because it's above the obturator internus. Muscle directly below the inferior gemellus. And then we know the muscle below the inferior gemellus is going to be the quadratus femoris. If you see a nerve that's going to one of these two muscles, the nerve that innervates the inferior gemellus and quadratus femoris is the nerve to the inferior gemellus and quadratus femoris. Spinal segments L4 through S1. And then directly above that, you have the superior gemellus right here and obturator internus, innervated by the nerve to obturator internus and superior gemellus that has spinal segments L5 through L2. And then over here, this is this image just to help you go through and remember that the greater sciatic foramen and lesser sciatic foramen are really important because it can help you identify the structures that are running above and below these different muscles and identifying neurovascular bundles. Okay, with that, we're coming to the end of our video, but we've got two clinical anatomy points we want to point out before we close. So the first is bursitis. You might have heard about bursitis in other courses or previously in this anatomy course, depending on the content. But bursitis is an inflammation of kind of a fluid-filled sac that sits on different structures around the joints. So these are your bursa. So you have a bursa that sits over top of your greater trochanter. Remember, your greater trochanter is a spot of attachment for a ton of muscles. So it's really easy for this region to become inflamed. And when you get the bursa becoming inflamed, causing pain in the region, we call this bursitis. And the important point here is the greater trochanter is a very common spot for bursitis, and it will commonly present with pain on the lateral aspect of the hip. You can palpate directly over the greater trochanter, and someone's going to say, ow, don't do that, that really hurts. And you'll see people coming in saying that it hurts when they lay on their side. So when this happens, one of the common treatments is a corticosteroid injection. And with this, you can use it ultrasound guided for insertion of the needle, but because you know that there's not a whole lot of neurovascular structures over here on the lateral aspect of the thigh, because we now covered that, because you're going to the, what you can do is palpate the greater trochanter, you can insert the needle directly into this region and inject the corticosteroids. So that's greater trochanteric bursitis. Now, we talked about being able to insert the needle into the superior lateral region of the thigh, right over the greater trochanter, and it being relatively safe. But is there anything I should be careful about if I'm doing a gluteal injection? Well, absolutely. We have to be careful where we're putting in our needle, because if you look at the buttocks, if we do different quadrants, we know that we have a superior sciatic foramen and an inferior sciatic foramen, and if we are greater and lesser sciatic foramen, and if we insert a needle into these spaces, we're at risk of hitting neurovascular bundles. So this whole medial zone here, this medial quadrant, is a very dangerous spot to inject because you're at risk for hitting nerves and vasculature. As I come more lateral, it's a little bit safer because I'm not coming directly out of the foramen, but I still want to be a little bit careful with this inferior lateral gluteal region because the sciatic nerve is coming down and around. So the safest spot to inject into the gluteal region is going to be the superior lateral quadrant, right here where the gluteus maximus, minimus, and medius are. Okay, so that's the safest zone for injection. Now, what happens if instead I say, hey, I'm new to this, I couldn't really tell what was lateral and medial, and I end up injecting right here in the superior medial region? Well, we talked about, say I'm going directly above the piriformis muscle, and I hit that nerve that's associated. Well, that nerve would be the superior gluteal nerve, right? And the superior gluteal nerve is innervating my gluteus medius, gluteus minimus, and tensor fasciae lata of the thigh. And all of those muscles, as we can see here, are going to be working to have a common action of abduction of the hip. So abducting the hip, bringing the leg out laterally, assuming that this is the leg here. So if I damage that nerve, superior gluteal nerve injury, I can get a sign called the Trendelenburg sign or Trendelenburg gait. Normally, when my leg is planted, I use the abductors, such as the gluteus medius, minimus, tensor fasciae lata of the thigh, to keep my hips level. If there is injury, these muscles will no longer be working. So now when I plant on the leg that is injured, the hip will dip on the opposite side. So this is going to be indicating Trendelenburg side and Trendelenburg gait. So if you see someone walking and their hip is dipping when they plant on one leg, it indicates injury on the planted leg. specifically superior gluteal nerve injury. This is a really important clinical point. Here's how you test for it. You just have someone stand on one leg, and you see the hip drop, but the hip drop, the side of the hip drop, indicates contralateral injury on the opposite side. So that's a really important takeaway point here, as well as the safe zone for injection is going to be the superior lateral quadrant of the gluteal region. And with that, that will take us to an end of this video.